You want me to stop sharing?
It's okay, ma'am. You can keep it in the. Yeah.
Sir, you can start.
Yeah. Thank you, Sachita.
You can start, sir.
Thank you, Sachita. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Preeti Bandar ma'am, who is a specialist in obs and gynecology and fertility at Ferti Clinic Fertilization Center, Abu Dhabi. And she's master's in reproductive medicine and ART. And she did her MS and DNB, MSCOG, PGT-A MLS and DRM in reproductive medicine and gynecology at Grand Medical College, Mumbai. And currently she is working as a course director at Study MRCOG Medical Consultancy and a gynecologist and fertility specialist, Abu Dhabi, UAE. So with this, we welcome you for today's webinar, ma'am. And today's webinar is streamed through the Shield Connect, which is the digital platform of Shield. If you miss any part of this program, it will be available in the Shield Connect as well as Shield Connect page in the YouTube. And coming to the today's topic, in July 1978, the world has witnessed the successful pregnancy with first IVF. Since that time, advances surrounding the assisted reproductive technologies have experienced explosive development and growth. Indeed, what was in 1978 perceived by many as controversial medical curiosity has radically changed the prognosis of couples suffering with infertility and is responsible for an increasing portion of the world's birth. And many of the advances in ART have both increased success rates and offered a broad range of options to couples undergoing treatment. So now, without further ado, let me turn over the time to Dr. Preeti ma'am to talk on innovations in ART. Over to you, ma'am.
Thank you, Dr. Someshwar, for the kind introduction, and thank you, Shield Connect, for giving me this opportunity. So today's topic that I'm going to elaborate the audience about is innovations in artificial reproductive technology. So I'm going to talk mostly about what are the recent advances and the recent things what we are doing in day-to-day practice, as well as what is the way forward in these technologies. So this is my short introduction, and it's already given by Dr. Someshwar. And I'm a fertility specialist working in Ferti Clinic Fertilization Center in Abu Dhabi, United Arab Emirates currently. And this is the place where I work. This is our setup. We have a standalone center, IVF center, where we do not only the IVF, but also the pre-implantation genetic screening, and everything is offered at one place. And we have a very nice holistic approach towards providing infertility treatments for our patients. And I bring greetings to all of you from our center as well. So the learning objectives for today's discussion are to understand the new techniques that are being used in ART and how these have led to the emerging evidence and the latest and the new studies, how they're coming up regarding this, to outline the suitability of innovations in assisted reproduction treatments for different categories of patients. I will also explain the principles of various innovations in assisted reproduction treatments and their clinical utility, because that's the most important thing. Describe the disadvantages associated with newer techniques, and summarize the outcomes and success of the innovative techniques to improve pregnancy rates, because that's the final objective of any fertility treatment. So this is just a recap or a quick brushing up through the process or the actual steps involved in any ART cycle. So whenever anyone is considering the in vitro fertilization, it involves certain steps. So the first and the foremost step after doing the workup of the couple is controlled ovarian hyperstimulation, Followed by that, there would be a final follicle maturation trigger. Then comes the oocyte and sperm retrieval. So basically, the gametes come into picture at that time, and then the embryology process starts, whether it is IVF or ICSI. That starts at this point. Then the monitoring of embryos. So the laboratory work has started from here onwards. Then there is an intrauterine embryo transfer, and luteal phase support is the final step of this any ART cycle. So with this brief recap about what we do in the IVF cycle or the ART cycle, I move on to the innovations that I'm going to discuss today. So these are the 4 important innovative techniques that I'm going to discuss with the audience, and pre-implantation genetic screening is the first one. Then comes the ERA test, that is endometrial receptivity array test, time-lapse technology, which is called as TLT, and artificial intelligence in that is AI in IVF. So these are the things that I will be discussing with you today. So let's start with the first one, that is pre-implantation genetic screening. So commonly we call it as pre-implantation genetic testing for aneuploidies, and it is abbreviated as PGT-A. It enables the selection of most competent embryos for transfer. It avoids aneuploid embryos that would be destined for failure. So logically speaking, the reproductive outcomes would be considerably improved if we transfer genetically tested, and that to euploid embryos. It facilitates the implementation of single embryo transfer policies. Thereby, it mitigates the risk of multiple gestation and the associated complications with that. But are we going to offer this technology to a specific group or by and large to everyone? So no. The patient groups that are selected for offering pre-implantation genetic screening or testing are the advanced maternal age, recurrent miscarriages, and repetitive or recurrent implantation failure group of patients. So we will just see one by one how in these particular groups this technology helps, and what are the studies or what is the evidence regarding that. So regarding advanced maternal age, it's the most common indication for PGT-A in today's practice. So advanced maternal age, so how advanced we are going to offer this technology? So advanced age mostly refers to any woman who is above 37 years old. But although the recent trend is that we lower the age to 35, because we have found that the genetic errors can increase after the age of 35, and we can also consider after 35 offering pre-implantation genetic testing. A very large trial called as STAR trial started comparing the results when we transferred genetically tested embryos against just the embryos transferred by morphological testing, the conventional way, what we followed for so many years. So the subgroup analysis found that in 35 to 40 years old age group, continuing the pregnancy rate was significantly higher per embryo transfer for the embryos which were tested with PGT-A as compared with the morphology testing alone. And the genetically tested or the PGT-A tested euploid embryos, when they were transferred, the pregnancy rates were 50% as opposed to 37% when only morphological testing was done. Now coming to another retrospective study. So in women aged above 35 years, this study compared the reproductive outcomes before and after the implementation of an elective single embryo transfer strategy. So SET was done using PGT-A, that is trophectoderm biopsy was done, and that significantly reduced multiple pregnancy rates. It maintained cumulative pregnancy and delivery rates as well. And it significantly increased live birth rates per transfer of embryos. So these were the studies and evidences for or in favor of doing genetic testing or going ahead after testing these embryos for genetic abnormalities and transferring only euploid embryos in women with advanced maternal age. Now let's move on to another indication, and that is recurrent miscarriage. So how it helps in this. So idiopathic recurrent miscarriage most likely to be caused by embryo aneuploidy. That's the commonest cause. So a recent review concluded that in women who previously suffered miscarriages caused by aneuploidy, PGT-A resulted in significantly higher implantation rates and lower miscarriage rates. Also, there was a case series which was released recently that assessed the use of PGT-A, and there either a cleavage stage biopsy or a trophoectoderm biopsy was done for cases of recurrent idiopathic recurrent pregnancy loss where women had 2 or more losses, and the miscarriage rate following PGT-A was only 6.9%, as opposed to 33% in a recurrent pregnancy loss control population, and it was 23% in infertile control population. So as you can see, the PGT-A has significantly lowered the miscarriage rates in these women where there were recurrent pregnancy losses. Now, what did another retrospective study demonstrated? That there was a significantly higher implantation rate, 52% versus 19%. The clinical pregnancy rates were 69% versus 43%, and the continuing pregnancy rates were 61% versus 32%, where it compared the cycles where genetically tested euploid embryos were transferred against the morphological testing of the embryos. So significantly fewer multiple pregnancy rates in women who underwent PGT-A than in the controls were also found, because this gives us an advantage of transferring a euploid single embryo, and thereby it also helps us to reduce the multiple pregnancy rates. Now, the third indication, as I told you, is repetitive implantation failures. So this is the area where we have a very limited data as of now for this group of women, but how the studies guide us. So there was a very large retrospective study, and they divided women into different groups. So the first group was recurrent implantation failure. In those cases, PGT-A was offered, means a trophoectoderm biopsy was performed on the embryos and single embryo transfer was done. The second group in this study was not actually having repetitive implantation failures, but just because of other indications, a PGT-A was used, like advanced maternal age, etc. And the third group was recurrent or repetitive implantation failure, but PGT-A was not used, and either a single or a double embryo transfer was performed in these women. So what was found in this retrospective study, that when a recurrent implantation failure with PGT-A group was compared to a recurrent implantation failure where PGT-A was not offered, the result showed that there were higher implantation rates in the RIF PGT-A group than in the RIF non-PGT-A group, and that was significant. It was 68% in this group as opposed to 22% where PGT-A was not used. So that is a significant number. And another inference was that when the group of RIF with PGT-A was compared with women where PGT-A was offered, but they were not the cases of repetitive implantation failure. So in this group, the difference between implantation rates in the two PGT-A groups with and without RIF was not significant. So again, what this retrospective study showed is that in women with repetitive implantation failure, if we offer them pre-implantation genetic testing for aneuploidy and then even we do a single embryo transfer, our implantation rates are definitely going to be higher. So PGT-A and SCT may improve implantation rate and the success of IVF cycles in women with RIF, and further high quality studies are still needed in this area. So I said trophoectoderm biopsy. So I want to explain little bit about these biopsy and what stages we biopsy these embryos. So what are the potential sources of cellular material for PGT-A? So as you can see in the first picture, initial stages or in the inception phases of this PGT-A, the embryologists, they were doing first and second polar body biopsy, that is the biopsy from these polar bodies. Then came the cleavage stage biopsy, that is biopsying a day 3 embryo, where 1 or 2 blastomeres were biopsied and they were tested for the genetics. And now what we follow most of the times is the day 5 biopsy, and we call it as blastocyst biopsy. So where we collect 5 to 10 trophoectoderm cells, like you can see here from this portion of the trophoectoderm, and that's why we call it as TE biopsy, that is trophoectoderm biopsy, but it's nothing but a blastocyst biopsy, which is done on a day 5 embryos. So as I showed you here, that these are the 3 different types of biopsies that can be done on an embryo. So what are the advantages of trophoectoderm biopsy? Over the years, why we shifted to trophoectoderm biopsy? Because it is known to cause less damage to the embryo. We get more material for analysis. There are low rates of mosaicism as compared to cleavage stage. It embraces the concept of natural selection, because we know the embryos which are going up to day 5, they are the ones which are the most fit for the survival. So here it's embracing the concept of natural selection. So blastocyst stage embryos are more likely to be euploid as compared to a cleavage stage embryo. The biopsy technique is less operator dependent for blast biopsy, and there is a more consistent reproducibility. So there are so many advantages of trophoectoderm biopsy. So that's the reason over the years we have shifted from a day 3 to day 5 embryo biopsy, that is from a cleavage stage to a trophoectoderm biopsy. So PGT-A has so many advantages in cases of advanced maternal age, in cases of recurrent miscarriage, and repetitive implantation failures. So are there any disadvantages? Yes. There is a cost involved in this treatment, which may not be affordable for some of the patients. The biopsy might potentially harm the embryos, but as again, I would like to tell you, the chances of harming the embryo, which were much more in a cleavage style biopsy, and as compared to that, when we have shifted to a trophoectoderm biopsy, this problem, we are not worried that much. There is always less than 100% accuracy. We can't reach the 100%. There is lack of research about detection of mosaicism and its clinical implications. And there is an argument that there are insufficient randomized control trial data to justify the routine implementation of PGT-A still. So these are some of the disadvantages, though it gives us a lot of information and lot of good evidence for using it for selected population of women. Now coming to a process called as blastocentesis. So this is something new and the research is still underway. So what it is? So it's a method of pre-implantation genetic testing for aneuploidy, and it's currently being investigated. Aspiration of blastocelic fluid means from the cavity of the blastocyst, we try to aspirate the fluid through the pipette that contains DNA and certain proteins responsible for regulation of various processes during the embryo development. Issues obtaining sufficient DNA from the fluid sample is one of the hurdles in using this process. There are false positives and false negative results, and the range can be from 0 to 7%. And the fluid collection involves an element of embryo manipulation. So again, it's kind of an invasive method, again, for pre-implantation genetic testing. And still, we are not using it, but this is one of the recent advances and the research is underway. So as I told you, we will discuss the 4 important things. So the first one was PGT-A, and now we move on to ERA test, that is endometrial receptivity array test. So what is it? So what it does, it assesses the endometrial receptivity status of infertile patients. It provides an opportunity to personalize the embryo transfer by synchronizing with each patient's window of implantation. It increases the success of treatment, particularly in couples with recurrent implantation failure. So in the picture on the right side, what you can see here is number 1, or day 1 is the beginning of the menstrual cycle. We know that around 14th day, the ovulation happens. And then around the 5th day, it is the most receptive endometrium. So the ERA test basically calculates the exact period or the exact window of implantation. So what we do in ERA test is we do the endometrial biopsy. We perform certain genetic studies on this material. The report comes, and then we decide for the next cycle how we are going to transfer and which day is the best for the transfer. And when the endometrium is most receptive, we plan for a embryo transfer. So this is the concept of implantation window. As you can see, the time of maximum endometrium maturity, it is commonly called as implantation window. For most women, it is from 19th to 21st day of the menstrual cycle. So as you can see here, this is the implantation window, the brown colored peak which is shown, and that follows the peak of the ovulation. So just to have a overview about, or the recap about the physiology of implantation. So what happens during that period? So the process of implantation in humans, it occurs in a very narrow time frame, and it involves a complex interaction between the blastocyst and the endometrium. So I always tell the patients while explaining, it's the same concept as the soil and the seed. So we are trying to make the best quality embryos in the laboratory, but what about the soil? It also has to be properly prepared, and then only the seed is going to grow there. So it's basically an interplay or interaction between the blastocyst and the endometrium. So during a natural cycle in a woman, the embryo enters the uterine cavity around 4 days after ovulation. The endometrium becomes receptive to the implantation of the blastocyst around 6 to 8 days after the ovulation and remains for the next 4 to 8, around 4 days. And in ART cycle, this process is artificially mimicked through administration of sequential estrogen and progesterone. So that's the reason sometimes we may not implant the embryos in the actual implantation window and the cycles can fail. So what are repetitive or recurrent implantation failures? So failure to achieve a clinical pregnancy after transferring at least 4 good quality embryos on the basis of morphological assessment in a minimum of 3 fresh or frozen cycles in a woman, then we call that particular condition as repetitive implantation failure. So significant proportion of patients with a history of implantation failure have displaced windows of implantation and may benefit from personalized adjustment in the timing of FET, that is frozen embryo transfer. So approach for individualized embryo transfer is particularly beneficial for subgroup of patients where they're encountering this repetitive implantation failures. So how do we get the interpretation or the results of this ERA test? So when we get it as receptive, that's what we are looking at when we do this endometrial biopsy. So what do we do when we get a receptive endometrium? So on the next cycle, the same schedule will be followed, and after the hormone support cycle, the blastocyst transfer will be done. And what if we get the result as non-receptive? So the non-receptive can be either pre-receptive, that it's too early, or it will be either post-receptive, that it is too late. So if it is pre-receptive, that is too early, then on the next cycle or during the hormone support cycle, the start time of the progesterone until the transfer will be lengthened depending upon how is the result of the ERA test. And if it is post-receptive, that means too late. That means on the next cycle or during the hormone support cycle, the start time of progesterone until the transfer will be shortened. So this is how we interpret the ERA test, that is endometrial receptivity array test. Now with that, we move on to our third innovation to discuss for today, and that is about TLT, that is time-lapse technology. So basically, time-lapse technology is used for selecting the embryos. So what are the other methods that we follow for selection? So as we discussed before when we were discussing PGT-A, that is the conventional one, is the morphological assessment of the embryos. Then comes the embryo biopsy with pre-implantation genetic testing, and we just discussed so many advantages of that, and in the especially certain patient groups like advanced maternal age, recurrent miscarriages, that is recurrent pregnancy losses, and in cases of recurrent implantation failure. And then comes the third method of embryo selection, and that is time-lapse microscopic photography, that is TLM, or TLT, that is time-lapse technology. So what is time-lapse technology and when it became available? So it was commercially available for the human IVF from 2009, and it has evolved over the time. It is a system used in some laboratories to facilitate embryo monitoring. The images of embryo development are recorded at regular intervals of 5 to 15 minutes. It allows the embryologist to assess embryo development thoroughly in a dynamic fashion without removing them from the incubator. So that's so important that we are not removing it from the incubator and we are preserving the environment that is required for the embryos. So specific computer programs will assist in the assessment of embryos based on changes in the shape or structure occurring over time, and they help in ranking of embryos depending upon their developmental ability. So how the TLT has helped us? So the introduction of TLT has enabled two things: increase in the number of observations of the embryos and dynamic assessment of the developing embryos. So basically it offers an uninterrupted culture environment, minimizing the embryo handling and the need to expose embryos to conditions outside of the incubator. And the other name for this is embryoscope, and it's nothing but a time-lapse technology. So this is how an embryoscope or a time-lapse technology looks, the machine looks, and there is a screen which gives the embryo pictures at a set time, whether it is 5 minutes, 15 minutes, how we set the machine, accordingly we get the embryo pictures. So it typically comprises of a standalone incubator with one or more integrated inverted microscopes which are coupled to a digital camera. The digital images collected at regular intervals and at different focal planes throughout embryo development, and they're subsequently processed into videos. It enables the embryologist to record pre-implantation embryo development in a dynamic, real-time manner, and it permits the interpretation of morphokinetic events more precisely. And the data from these observations can be annotated and they can be analyzed using integrated TLT software. It facilitates the development of more complex embryo selection or deselection algorithms. So this is how it gives a lot of information to the embryologist about the embryos. So is there evidence of a clinical benefit? So the latest Cochrane review, which included 9 RCTs and 2,955 women, and that came out in 2019, reported actually insufficient evidence for differences in live birth rates, miscarriage rate, or clinical pregnancy rate for TLT combined with embryo selection software versus conventional incubation and assessment of embryos. The cumulative live birth rates were assessed in another retrospective study in 1,882 cycles, which compared time-lapse and conventional incubation or assessment. And this study showed similar cumulative live births for time-lapse and conventional incubation or assessment, although fresh embryo transfer live birth rates were quite higher for the TLT cycles. So then, should we use TLT? And if yes, why? So despite the current lack of evidence from the RCTs for a clinical benefit of TLT, it's worthwhile and it's logical, whatever you can say, it's reasonable to assume that as compared to static observations, continuous embryo monitoring in an undisturbed environment will offer more information into embryo development, and it is expected to enhance the identification of good prognosis embryos for clinical use. So this is the positive thought that we can give about TLT at the current moment with whatever evidence available for or against TLT. Now we move on to the fourth innovation, which is still underway and it's not available in most of the countries until now. And this is a very special technique, which is still not in a very routine use, and that is about role of artificial intelligence, that is AI, in IVF cycles. So what are the places where we can actually use AI? So we can use it in the treatment regimens. We can either use it for the gamete selection, and also we can use it for embryo selection. So in the treatment regimens, it can assist the clinician in developing an optimal patient-specific treatment regimen to improve the IVF success. Artificial intelligence can also help in gamete selection. It can aid the embryologist in selecting the best oocyte and sperm combinations. And it can also predict embryo quality, and thereby AI can also help in embryo selection. Let's see one by one how we can use this. So basically, in the IVF clinic, the decision-making of an IVF cycle regimen, it depends upon the patient age, the ovarian reserve of the woman, her medical history, and there are many more other factors which we take into consideration for selecting the dose of gonadotropins and the treatment regimens and the kind of protocol that we are going to use for controlled ovarian stimulation. So objective decision making to optimize the treatment protocol for the best outcome, this is what can be given by the AI for treatment regimens, and it can help us to make personalized protocols by artificial intelligence. Now coming to the use of AI in gamete selection. So can it help us? Yes. So AI would remove the subjectivity of human assessment from the decision-making process, and it will objectively rank the gametes based on the quality. Artificial intelligence has also been applied in semen analysis to evaluate sperm morphology, DNA integrity, and for sperm selection as well. So the greatest benefit should come for selection of sperms for the ICSI, that is intracytoplasmic sperm injection, and this is what we are looking at currently. And AI may compute the optimal sperm egg combination to achieve the highest success rate, or perhaps determine whether IVF or ICSI is the best fertilization approach, because in some of the cases we are not sure whether we should go with a conventional IVF or whether ICSI can help. So this can be better guided by the artificial intelligence in days to come. It can complement current clinical practice while offering objective gamete selection to substantiate the assessment made by the embryologist. Then coming to the artificial intelligence for embryo selection. So can it help us in that? So what are we doing currently? So morphological assessment of embryos is the most commonly used process to select embryos for transfer. But what's the most important disadvantage? There is a high interoperator variability and inconsistency in this selection process. So the current focus of AI applications in embryology, basically it looks at the automatic annotation of embryo development, like the cell stages and the cell cycles. It's looking at embryo grading, mostly at the blastocyst stage, and it's also it can help us for the embryo selection for the implantation, and we can it can predict which are the best embryos to give us best implantation or the higher implantation rates. Also, implementation of AI in the embryo grading and selection process will provide an objective and accurate prediction of pregnancy and live birth rate outcomes. So looking at the advantages of AI, yes, there will be lower error rates in the tasks regardless of the external environment. There will be lower error rates in performing labor-intensive and tedious repetitive tasks, and lower error rates for organizing medical records as well. And logical machine thinking will be there without the emotional factors or the physical constraints. But yes, along with that, some disadvantages also come. So there is a high initial cost of deployment. Again, we have to look at the ethics of relying on a machine to replace human decision making, because that human touch will be lost. There will be absence of human connection. Most clinics are too small in isolation to have sufficient data for using artificial intelligence for all their cycles. There is limited computing power and data storage. So these are the current disadvantages for considering artificial intelligence for any IVF clinic. So what is the way forward in this? So artificial intelligence driven approaches are likely to be more objective, more rapid, and most importantly, they are going to be most accurate. Incorporating AI into IVF clinic may be the next frontier in the journey towards personalized reproductive medicine and improved fertility outcomes for patients. AI will likely aid clinicians in devising patient-specific treatment regimens before and after oocyte collection, as well as improving gamete and embryo selection. We should evaluate artificial intelligence not only by the capacity to enhance existing clinical assessments, but on their ultimate improvement to real clinical targets like live births and IVF. So that will be the real advantage if we are going to get something out of it, like improvising not only the implantation rates, but also the live birth rates. So these are some of the references from where I have obtained this material for my today's talk. And so really it's an exciting journey, and still an exciting journey lies ahead. So thank you very much, and many thanks to the audience for listening to my today's talk about innovations in ART. So I'm happy to take any questions from the audience. And I once again thank Shield Connect for giving me this opportunity to present this wonderful topic in front of large global audience. So thank you very much.
Thank you very much, ma'am. We are very honored and learning to hear you, ma'am. It was very excellent presentation and innovations in ART. And ma'am, if you allow me, then we'll take the questions.
Yes, we can take some questions if we have time.
Yes, ma'am, we have the time. Ma'am, we have a first question, that is, which is the ideal day to perform embryo biopsy?
Okay, so regarding this question, it is a very good question because it all depends upon what we are looking at. Like depending upon the patient needs, we may have to change the embryo biopsy day. For example, as I told you, right now with the current scenario and having so many advantages of trophectoderm biopsy, at our center, most of the biopsies are day 5 biopsies. That is the blastocyst biopsy. It's also called as the trophectoderm biopsy, because there are so many advantages. We are not losing the blastomeres. We are causing the least damage to the embryo. So if you ask me the ideal one, it's day 5. But I will tell you one thing. Sometimes what happens is that we have certain patients where we need to go ahead with a fresh transfer. And at our center, the turnaround time for a biopsy report for a PGT-A is 24 hours. So if we are planning for a day 5 biopsy, there is a technical point in this, then we always go for a day 3 biopsy because we have to transfer the embryos on day 5. Right. So if we do a day 3 biopsy, on the 4th day, we get the result and we know, yes, these are the euploid embryos, and then we go ahead with a fresh transfer on the day 5. Well, this problem does not happen if we are going to freeze all the embryos. Then we always like to take the embryos to day 5. So we do the biopsy, freeze the embryos, wait for the results to come. And whatever are the euploid embryos, we transfer through a remote cycle, that is a frozen embryo transfer cycle, which we do remotely, maybe in the next month or the next month to that, depending upon how the patient wants it. So, but if you ask me what is the best one, it is the day 5 biopsy.
Thank you very much, ma'am. Ma'am, we have one more question, that is trophectoderm biopsy or polar body biopsy. Which one to choose and how?
Okay, so currently for PGT-A, at least in our center and here, this part of the world, we are not doing polar body biopsy. Okay, so polar body biopsies were done when it was in the inception phase, the pre-implantation genetic screening. But then in today's day and age and practice, we do either a cleavage stage biopsy, that is a day 3 biopsy, or we do the day 5, that is a trophectoderm biopsy. So again, if you ask me, the most preferred one would be the day 5 embryo biopsy, that is a blastocyst or a trophectoderm biopsy.
Thank you, ma'am. We have one more question, ma'am.
Mhm.
Can we check autosomal dominant diseases with PGT?
Yes. So for autosomal dominant diseases, especially, we need to see like which chromosome is affected. And if we have to do that, we have to make certain probes and we inform the lab. For example, if the couple is both are thalassemia carriers, and I'm just giving an example. Again, that is a autosomal recessive, but just for example, I'm telling you. And then if we are thinking like the child is at a risk of getting the thalassemia major, that is the disease. So in that case, we need to inform our genetic lab in advance, and they have to make the chromosome specific probes to check for autosomal disorders. And that is the only way to diagnose autosomal dominant or recessive conditions. But yes, we can do that, and we are doing it regularly for some of our patients where there is an actual genetic reason to test other than the three reasons that I discussed for PGT-A.
Yeah, thank you, ma'am. I guess I've understood that if anything is like monogenetic disorders or which are linked with chromosomes, could be the we can check with along with the PGT. Yes,
Yes,
ma'am.
definitely. Yes.
Thank you, ma'am. And I guess there are no more questions from the delegates, ma'am. If you allow me, then we'll close this session.
Sure. So thanks once again, and we can wrap up this session. And thanks for your patient hearing.
Yeah, thank you very much, ma'am. And we are very honored to have you, ma'am. We look forward for your continuous support for this educational initiative. Thank you very much, ma'am. Many thanks from the Shield team.